Thank you very much for inviting me to participate in this meeting. Thank you, Eugenia, for inviting me another year. I'm a geriatrician, so I used to treat very old patients with a mean age of 90 years old, patients with multimorbidity, polypharmacy, patients with mental problems like dementia or depression, with functional problems like disability, frailty, or poor social support. All these factors influence their quality of life. And to assess properly this type of patient, we use geriatric assessment. That is the appropriate method to bring out all the problems and make a holistic care plan. In this presentation, I will try to explain how we treat a patient with multimorbidity and polypharmacy. Here are some websites or papers that could be useful if you go deep in this topic. Some of them signed by the group of Giovanni Guaraldi. As defined by the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of illness. So we can say that health is a table that is supported by 4 legs: one leg medical, another physical, another mental, and another social. So if we want to know the necessities of an old patient, we have to assess these 4 aspects. That's why geriatricians use geriatric assessment. That is a multidimensional, interdisciplinary diagnostic process to determine the medical, psychological, and functional capabilities of a frail elderly persons in order to develop a coordinated and integrated plan for treatment and long-term follow-up. For medical assessment, we assess illnesses and also nutrition, and also the whole medical treatment. For physical assessment, activities of daily living or gait speed, mental assessment to diagnose or rule out confusion, depression, or dementia, and social assessment, the presence of appropriate caregivers, friends, family, finances, and so on. Geriatric assessment involves several processes that can be divided into 6 steps. First of all, we have data gathering, discussion among the team, including the patient and the caregivers or relatives, development of this treatment plan, implementation of the treatment plan, monitoring the response, or revising the treatment plan. And choices about goals of care must be made about what outcomes are most important, mainly for the patient and the relatives, and also for the doctors. Outcomes must be patient-centric and individualized. Outcomes are very varied, regarding a previous health status, living at home, completing 8 years without help, control pain, survival, and so on. With the advances of the therapy in HIV-infected patient, now this illness has transformed into a chronic illness. That's why patients now living longer. And today, patients are very different from those for whom the same services were designed years ago. They are different because they are older, with more comorbidities, with more medications. They also have mental, physical, and social problems. And this burden of multimorbidity and polypharmacy is expected to increase in the next years. I'll try to explain how we geriatrics used to work with a clinical vignette. Here we present an 83-year-old man that is referred to our outpatient consultation from infectious disease medicine because of his comorbidity. He is diagnosed of diabetes, hypertension, chronic heart failure, chronic kidney disease, knee osteoarthritis, and he was diagnosed HIV positive in 1993. His last viral load was indetectable. So we can say that this patient has multimorbidity. Multimorbidity is defined as the accumulation of multiple serious chronic health conditions that threaten functional and or cognitive status. Illnesses like cardiovascular, liver, metabolic, chronic kidney disease, cognitive dysfunction, osteoporosis, and so on. The prevalence of multimorbidity in HIV-infected persons is around 50%, 40 to 50%, much more than the same age individuals without infection of HIV. And importantly, multimorbidity are now a major driver of hospitalization in this population, and non-AIDS mortality has eclipsed AIDS-related mortality as the major cause of death in this population. And also, more than 50% of HIV-infected persons presents 2 or more geriatric syndromes like frailty, dementia, depression, malnutrition, disability, dependency, incontinence, falls, and social isolation. Our patient, he can confirm his complete medical treatment in the first consultation. We have to talk with primary care physician to know that he is in treatment with abacavir, lamivudine, nevirapine, metformin, lisinopril, furosemide, paracetamol, and tramadol, and for knee pain, and also bromazepam. And he is visited regularly by primary care, infectious disease medicine, cardiologist, endocrinologist, nephrologist, orthopedic surgery, and recently by a psychiatrist. So we can say that this patient has polypharmacy, and also he is in danger of care fractionated. Polypharmacy is defined as taking 5 or more medications, and older persons are often prescribed multiple medications by different health providers. And this polypharmacy increases the risk for drug-drug interaction, advanced drug events. Different cohorts have described a 15 to 20% of polypharmacy in HIV-infected population. And importantly, this polypharmacy increases the risk of functional impairment, falls, fractures, delirium, undernutrition, hypoglycemia, pneumonia, institutionalization, hospitalization, and also death. So polypharmacy is a danger illness. There are a lot of clinical guidelines, recommendation, and also clinical tools like stop-start criteria for helping inadequate prescription of this kind of patient. There are some of them. It is important to evaluate the list of drugs that really taken the patient and every clinical contact. In my experience, the best method is to ask the patients to bring all the bottles with them in the visit and check every single medicine, asking, is it really necessary now, this medicine? Is there any necessary drug not actually prescribed, like for instance vitamin D or anticoagulant? And explore social and economic issues that could affecting the patient's adherence and compliance to the recommendation. Try to simplify the drug prescription, and in geriatrics we also use the general rule that start low and go slow. So we are treating a patient with multimorbidity and polypharmacy that threaten the health status through different ways. He could have a care fragmentation because he is visited by a lot of specialists. He's in danger of iatrogenic illness because the specialist may focus on one single disease and prescribe treatment that may worsen another patient conditions. If we try to get to follow the specific guidelines for every illness, one recommendation may clash with another, and multiple concurrent treatment may increase care burdens without benefit. And there also a risk for drug-on-drug interactions and non-compliance. And most important of all this risk is that polypharmacy and multimorbidity place patients at increased risk of functional decline and disability. Our patient, assessing the functional ability of our patient, he says that he is still independent for all 6 activities of daily living. He is independent, totally independent. But he said he has more difficulties than 3 months before, especially for climbing stairs. So we could be at the start of a decline process in the functional capacity. He thinks that this is for knee pain that has limited mobility. Also, he refers 3 falls outside the home in the last 3 months. He feels very weak and tired the whole day. He has lost 8 kilos in the last 6 months, mainly because he feels anorexic. He used to lunch well, but he uses to dinner just 1 piece of fruit. And he has been skipping meals since he has difficulty to go grocery shopping. So we can say that our patient that is multimorbidity and has polypharmacy, he's also in risk of functional impairment, he has falls, and he's in a nutritional risk. Christine has explained a lot about functional status. Just let me insist that functional status is a very important factor in the quality of life of the elderly, and this is a very good prognostic factor of mortality, recovery of acute illness, institutionalization, length, and cost of hospitalization. And very important is that disability or dependency are not the unavoidable final result of all elderly. They are preventable and also avoidable. Just a word about frailty, that also frailty is said that frailty is a pre-disability state. So this is very important to diagnose frailty at the first stages, because as soon as we intervene, we can stop this decline process. Physical exercise, adequate nutrition, and also medication review are the most useful strategies to prevent or reverse frailty. This is one of the best figures to show what frailty is. If we see here, we saw here the stressors like hospitalization, surgery, drugs, infection. Fit person has robust adaptive capacity and resiliency to the stressors. But in the middle, frail patient or frail patient had weak or poor adaptive capacity and resiliency, and this drive to poor outcomes like hospitalization, death, or a physical impairment. Frailty is highly prevalent in HIV-infected persons, around 30%. In a recent paper published by Dr. Brañas in Age and Aging, in a cross-sectional study in 2 public hospitals in Madrid, the prevalence of frailty was 50%, and the prevalence of pre-frailty was 52%. So following with our patient, the mental evaluation reveals he has symptoms of depression because of his physical evaluation and the health situation of his couple. This is the beginning of the end. He has no suicidal ideation. He is cognitively intact with no symptoms. He lived with his couple for the last 20 years, but he is very ill with a colon cancer diagnosed 3 months ago. They lived in a 3rd floor without elevator. So maybe our patient, we think about he is depressed, and also he has poor social support. We can use some geriatric depression scale to assess depression. And on examination of our patient, his blood pressure is 110/55, heart rate 88, weight 59 kilos with a body mass index of 20.7. His gait speed is slow, 12 seconds in 6 meters, 5 meters per second. And the time up and go test is 17 seconds. So we can say our patient is undernourished and he has a slow gait speed, maybe he is frailty. We can use one of the scales that Christine has explained before. This is the frail scale. It's very easy to check in the patient, and our patient has 3 or 4 points, so we can consider that our patient is frail. His glycated hemoglobin is 6.5, and vitamin D is 19 nanograms per milliliters, so he has deficiency of vitamin D. So after more or less 45 or 50 minutes, we can elaborate this problem list of all the problems that our patient has. He has multimorbidity with diabetes, hypertension, chronic heart failure, chronic kidney disease, osteoarthritis, HIV. He has polypharmacy. He is frailty. He has the first stages of functional impairment. He has falls. He has weight loss. He is undernourished. He has vitamin deficiency. He is depressed, and also he has social risk. And now After every problem, we have to make a care plan. For multimorbidity, one of the main goals of care is avoid the care of so much specialists, and defines clearly the goals of control of diabetes. We can be more permissive with the control with the glycemic control, with HIV A1C 7.5 to 8, and also the same for the control of blood pressure. It is better for this patient to have his blood pressure around 13 or 14 than around 10 or 11. Polypharmacy, which should suggest we can decrease the doses of metformin, we can decrease the doses of lisinopril and furosemide. Maybe both of them can contribute to the falls and functional impairment. We suggest avoid tramadol, increases with paracetamol, and bromazepam. For frailty and functional impairments, Christine has explained what kind of physical exercise we can do to try to improve this function and increase the muscle strength. He has weight loss, he is undernourished. We can make some dietetic recommendations, increase the intake of nutrients, and maybe we can suggest the use of caloric or proteic supplementation. We have to give him supplements of vitamin D, and for depression, maybe we can use mirtazapine. This is not the best antidepressant medicine, but also we can use it for insomnia and for increases the appetite. And maybe we can put him in contact with social worker to increase the social aids. So, in conclusion, the change of this type of patients doesn't fit in the traditional models of care. So if we continue to work like this, the health system simply will collapse. So it's mandatory to organize the system to work coordinated in multidisciplinary teams, including physicians, nurses, social workers, physical therapists, pharmacists, and so on. And this care should be provided through integrated, multi-level system, following patients through all the different settings that he is treated, coordinating between transitions to avoid conflicting intervention, duplications, and errors. So now the patient is with a new paradigm, more based mainly on function, based on function and also in geriatric syndromes, chronic conditions, and this intervention should be person-tailored. It is mandatory to assess physical, mental, and social function in order to identify the most vulnerable older adults. And geriatric care might be promoted by facilitating interdisciplinary exchange between geriatricians and infectious disease specialists. Maybe we can use some of our experience, like instance in orthogeriatrics wards, when we demonstrate that this collaboration is benefit for the patients. And geriatricians can provide the background and initial models for building up specific tools adapted to these HIV populations and capturing the clinical complexity and peculiarities of these patients. Thank you very much.